Hi, everyone. Welcome to our EDTC QI open call today. So really excited to continue this conversation on how we work on the EDTC documentation to raise the EDTC composite score across all of the CAs in Minnesota. I just want to highlight what amazing and great work you have all been doing. Robin and I have been doing a lot of the individual calls with many of you, and just really, really inspired by all the amazing stories that you guys have been able to do around this measure. We also want to acknowledge, this is like one piece of the work that you do, and you guys, you have so many other priorities that you all have to work on. And the fact that you're also taking the time and putting EDTC documentation as one of your priority is really, really amazing. And also what you are able to accomplish with that. So kudos, props to you. Again, really fantastic work. So inspiring again. And, I always tell Robin, I just wish we kind of had a forum, Robin, to share all the great success that the CAs here in Minnesota are doing with other hospitals across the US. And just, it would be so great because Robin and I, we are just doing our happy dances each time we talk to you. So. All right, so the call today is really, we want to continue discussion, what are some of those best practices around raising the scores on the EDTC measure. We are going to have a few of you kind of start off with some presentations or just really a quick discussion on what you've done. So Kelly Rip from Perm Health and Cindy Thompson from Chai St. Francis Health we'll kick us off, with the overview of kind of their work, what they've done to raise and really continue sustain that improvement on the EDTC documentation and scores. And then we really want to have an open discussion with all of you and have you all chime in with your stories of what are you doing around EDTC documentation? What are some of those intervention strategies, best practices? Robin and I can also share some of our impressions, but this is really a forum for you to be able to talk to each other, ask each other questions, ask us questions. So yeah, we are really opening it up to you. So maybe, do we want to call on Kelly first and have Kelly maybe kick us off about, the amazing work that her CA has done on EDTC, what they've done, what they've seen, and kind of how are they working to sustain that effort. So Kelly, if you have the slides, you can share them here on Zoom. If not, you can just also talk.
Good morning, everyone. I do have this available, so wasn't quite sure what to all share, but we'll go ahead and go through what I have. So I'm Kelly Reapy. I'm the Director of Quality Management here at Perm Health. We are a managed site of Sanford Health. So they are our tertiary site. And I should kind of preface that most of our patients that are seen in our emergency department, if they get transferred to another facility, it is typically Sanford Health, which we share Epic, and that does add a benefit to our organization and the ability to see the same notes that we have from our organization to them and vice versa. So not saying that we never ship to Essentia Health in Detroit Lakes. They are also on Epic, but their view is a little bit different. And then we also send our patients to Centricare, and we can ship to Gillette's and Children, really anywhere. But for us, the benefit that I do have for this organization is that we do mostly send to Sanford. So I just kind of took screenshots of our information. So when we use the abstraction tool, number one, does a medical record indicate that the current home medication list was sent? And I just took snipping shots out of our page, these were actual abstractions that I just did yesterday and today. into the tool that we use. And this is found right in our provider's notes. It can look different based off of the provider, where exactly in the notes it lies, but this is typically the spot that I look for under home medication. Is this a part of the provider or the patient's notes? And if I see this in there, then yes, they did receive that because it goes to the receiving facility. Number 2, does the medical record documentation indicate the patient's allergy history was sent? Again, it is a part of the note. I do look at this and it can look different, again, based off of the provider, where they have it located in their note, but I just look at that allergies. Another example would just a reminder that if it shows up in the note as no known allergies, you're still satisfying that measure by saying NA. I'm sorry, not NA, but that yes, it was reviewed. Just because they don't have any allergies doesn't mean it wasn't reviewed. So if this shows up like it did in mine, I say yes, it was sent on because we did review it and they didn't have any. Number 3 measure is about the medical record indicating the list of medications administered to the ED was sent to the receiving facility. So in our EPIC setting, we have this really nice care timeline that falls along the right side of the note. And it tells me everything from the time that they arrived to basically everything that happened during their visit. And you can see I've highlighted the example on the left was one patient and the example on the right was another patient. So these are 2 different charts and I just highlighted, these were all of the medications that were administered while this patient was in our facility. This goes with, or the tertiary site, Sanford, can see this in their record. And if they go to a secondary location for us, this goes with, so they are able to see all of the meds that were administered. So I would say yes to this one. Sometimes there are no medications that are administered, and this is an example that I just abstracted this morning. There were no meds. It was simply lab work while this patient was here. So in this example, I would do NA because no medications were administered in that abstraction tool. The 4th question is talking about, does the medical record document indicate that the ED note was completed by the physician, the AP, or physician's assistant and sent to the receiving facility? So here's where some of our work has really come into play. We have a spot in our provider's notes that is actually like a time-stamped piece. So as the provider is seeing that patient throughout the course of their stay, you can see the example on the left is the ED course. That's the note that the provider has made throughout their stay. And then I compare it with the care timeline to indicate how the care went. I know that there was some questions about, well, how do I know that the note was signed before the patient was sent? Or how do I know that information was put in and that the provider didn't wait until the patient was gone to do the documentation? In this note, or in the smart set that we have, the provider's information is time stamped, and whether the note is still open when the patient is transferred or if it's closed, I can still see that at the time that the patient was discharged, this information was documented and it was sent in the provider's or in that patient's information to that receiving facility. So that's definitely one thing that has helped satisfy this measure, is being able to see this and compare it to the care timeline. The 5th measure, or 5th question, does the medical record documentation indicate the mental status orientation and assessment was completed and sent to the receiving facility? So in our organization, I look for the Glasgow Coma Scale as an indicator that a mental status and orientation was completed. Again, the left side kind of shows you, well, they're actually both right underneath the physical exam where the provider starts to document their assessment. Usually either it spells it out as the Glasgow Coma Scale or GCS in the note, and it gives you the scoring. So I'm able to say yes to this one on both examples. Number 6 question, does the medical record document indicate that the reason for transfer or plan of care? This one, again, I go back to that ED course note, and I've highlighted in there where the provider talks about lab values being elevated, needing close monitoring, recommend to transfer to a higher level of care for further differentiation, of the chest pain. And then the second example talks about kind of the findings from a CT, the discussion that was had with the patient, and the recommendation for transfer. So that too, being a part of this time-stamped ED course does help us achieve that yes, or satisfy that measure. So the 7th question talks about, does the medical record indicate that information was sent regarding any tests and procedures? Again, I go back to that care timeline. It's kind of a quick reference. It shows me all of the different tests that were done. So again, the example on the left is one patient. The example on the right is a different patient, but you can see that I consider labs, EKGs, x-rays, CTs, any of those things to be testing or procedures that were done in the emergency department. So yes, those are a part of the record, and they are sent to that receiving facility or viewable by the receiving facility. And then, does the medical record documentation indicate the results were sent from the completed test? So again, I compare that timeline. And then underneath in our note, the physical examination is actually pulled in all of these different reviews. And I just took a very quick screenshot because I could have done pages and pages of what the results were from the CT head scan without contrast and all of that kind of stuff. So I'm able to see that all of that information was completed prior to them being discharged from our facility, and that they are part of the note which gets sent. So again, the patient on the left is one, and the information on the right is another patient. So that's what I do to satisfy the abstracting tool and the places that I look for the information. I guess what I had kind of talked to Robin and Sanka about was like checking all of the notes. If your provider does not have all of this information in the note, don't forget, you can look into nurses' notes versus the provider. If you don't find it one place, don't stop looking for it, but just make sure that where you do find it, you are making sure that that's a document. If it's a printed copy that is being sent to the facility, just making sure that that's included in there. Like I said, for me, the tertiary site of Sanford, they can look at flow sheets and all of those different things where maybe something might be hidden in there, but it's still viewable and it's still being sent. So and some of the ways that we were able to kind of implement these different things from a provider standpoint is really provider education, working on the smart sets and the templates that the providers use. If any other organization is also working with the trauma program or the stroke program, you know that you have to work with your providers to make sure that the NHISS is in there. So it's the same kind of work, making sure that they're hitting this criteria similar to how they're achieving the trauma program and the stroke work. So I guess I don't know if anybody has any questions for me.
I have a question, Kelly. Thank you so much. That was great. This is Lynette Anderson, and Just a question specific to that provider note, because that's a problem area for us. If you're sending outside of the Sanford system, how do you accomplish that if the note is still incomplete, or is your note usually completed and signed prior to the patient leaving?
Honestly, it's not, but they print off what is there. The nurses print off what is there, and that timestamp indicates that when I go back to it, if I look, where is that? You can see that here at 4:01, they had the conversation about the transfer to a higher level of care. And I compare that to right here, 5 o'clock is when they were discharged. So I know that that note was done prior to that patient being discharged, and it gets printed off and sent with them.
Perfect. Thank you.
Yep.
Okay, this is Robin, because remember, it doesn't, the part about being signed, and you might know this already, so just, I just want to reiterate that signed doesn't matter at all for this measure, unless it matters for when you can send something, or when when you're able to look at it in your record. I mean, that's a signature is only needed for well, it isn't needed for this at all. It's only whatever it might be needed for you to have access. I don't mean to confuse anybody, but I just want to make sure that everybody understands this isn't saying anything. Our instructions say nothing about a signature. So the signature only comes into play if maybe you can't see it without a signature, or the note can't be sent without a signature, or you can't make a copy and send, whatever. That's where the signature part comes into play. Not that it has to be signed before it can be sent to be included. Okay, I just want to make sure that everybody understands that. And then that word complete, when we've been talking with all you guys about this and kind of picking apart some of these words, maybe, that complete word is also confusing, because does the medical record documentation indicate that an ED provider note was completed? By completed, we're really meaning contains the information in that instructions that it says it needs to have, has to have a reason for the current ED encounter, has to have a history of the present illness. That's what we mean by, we're not saying completed. That's what we mean by completed. Okay, has that information that we're asking for in those instructions. Okay, so I don't want to mess anybody up when we're talking about that provider note, because I know that's the area where some people fall down. And I don't want anybody to be, marking themselves off when maybe they don't need to be. Okay.
And to answer the question that's in the chat, so it says, are you able to see the provider note at 4:01 at a later time so that you know what is included? So this is a picture of like literally what I just did. The one on the right was like 2 hours ago, and the date was April 18th of the encounter. So I'm able to see it way later, but I'm also able to see it in real time. If I actually pulled up this ED chart on April 18th I wouldn't be here at 5:30 in the morning, but if I was, I would be able to open up that chart and see it in real time as well. So it's time stamped in their note, just like any of the other nurses' notes. It's just kind of a part of their big template that they use. So I hope does that answer that question?
Kelly, can you hear me?
Yes, I can.
Oh, okay. I was having trouble with my mic. This is Holly in Thief River. So we use Epic too, obviously, because we're Sanford. But our ED notes, the ED course section is just like a narrative section. It doesn't have this time-stamped function. So is that a special like element you guys have pulled into your template?
I guess I would have to ask more from, I don't I don't know the logistics behind it.
Okay.
If the trauma and stroke people worked on it, but yeah, it definitely helps satisfy this measure. And I guess I'd have to look more into it. And Sanford we can't do anything individually at our site when it comes to Epic and implementation of different features like that. So it would have had to come from Sanford, like Fargo for us.
Okay. I'd be interested to see the name of that template if you're able to
Yeah.
find that out and send to me, because I'd like to take a look at that.
Sure.
Send that out to the group, because this is Robin from Riverview and Crookston too, and we too are IT affiliated with Sanford Fargo, and we don't have that time. We're not using that timestamp template, so that would be wonderful to know.
Sure.
Thank you.
Mm-hmm.
This is Tracy from Sanford Canby. I believe I've seen some of our providers use it and some not. So I think it's probably the template. Probably the ones that are good at using it are our newer providers, and maybe they had some training on that.
Yeah, that could be. I not to say that we meet this every single time. So one of the areas that I kind of identified actually yesterday as I was setting up for this was, so we had a patient roll in for trauma, and we have trauma level 1 and level 2. And when I looked at that note, they use a different template, so it didn't actually pull in their home medication. So that was one that I had to say no to. But so I think, yeah, it is very different, provider driven if they want to use it. Typical Epic, you have 100 ways to do one thing, and some people just get in the rhythm of doing what's comfortable for them. Maybe they don't know what they don't know, and how much it would benefit if they would just use that one template. Maybe it doesn't matter to them, and they're like, well, if it helps you, I'll use it. I don't care, kind of thing. So. Any other questions for me?
I'm just curious, those not affiliated with Sanford, and as you look at the template that Kelly has, do you all two have similar templates, or is it different, or is there something in her template that you're seeing? It's like, oh, I wish I had that. I'm gonna go back and talk to my IT and try to do the same. Does anything?
There's a long message in the chat. I don't know. Jody put it in there. I'm not sure who it went to, but it's someone that's kind of asking maybe that question about kind of similar to what maybe Senka is bringing up. And we've kind of talked about this before. We, meaning Senka and I, or Stratus, or the MBQuip program, however you want to put it, we don't know everybody's EHR. Everybody's EHR is different, even if you have Epic. As you guys are talking, this is what Kelly's Epic look like, but this is what, the Epic looks like in Thief River Falls. Everybody's is a little bit different. So, I don't want to say you have to have a template. You have to have these forms. It's whatever your record looks like, whatever data is available to you. The purpose, you got to always go back to the purpose of this measure, okay? That somewhere in the record, there's documentation that this information, these data elements that we're looking for, were sent to the other hospital. And I hate to sound like a broken record, and I wish I could be maybe more specific, but I can't, because everybody's system is so different. So that's the bottom line. Documentation that the data elements we're looking for in this measure were sent. It is kind of up to to you guys individually at your facility to look through those records and see where that information is. So, and I don't know who asked this question, so excuse me, you guys. I was at the dentist this morning and I'm all choked up. Why did I just lose my chat? Okay. So someone is saying, those not having Epic EHR would need to assess their EHR type, find where in their system similar documents that Kelly talked about are in place, then use as a standard document to look at to assess for measure specs. I don't want to say 100% the document's similar to Kelly, but Kelly's telling you in her record, these are the parts of her record. So this is where she's looking to find this information. So if your record kind of looks like that and you've got these documents, great. If your documents don't look anything like this, that's okay too. It's just that you've got to look for documentation that the data elements we want, whatever your provider note looks like, whatever, I can't be like more specific than that, it's for other sites that without Epic, they have to make decisions about how to get, okay. If other sites without Epic have such documents or ease to assess the measures variables, then they would have to make decisions about how to get these defined in their own EHRs and or figuring out how to get and see documentation that's necessary for review and completing the measure. It's like, yeah, I mean, really, again, we provide instructions. We want to make sure everybody understands them. Then you have to take those instructions and look at your record to see how it fits. Do people understand what I'm trying to say? I wish we could be better. I wish we could say, hey, this is what you have to look for. This is exactly what you have to look for. This is what but we can't because there isn't an exact. All we can say is these are the data elements. We're looking for documentation that they were sent to the facility. It is on you guys to look at your record and look in your record and find where that information might be. If it isn't anywhere, then okay, you're not answering yes, and you're working on processes to make sure that it's in there.
Yeah, Robin, and I'm sorry, I pulled this screen, I shared my screen again because there was a question about I do not see the history of the illness, reason for transfer. I've deemed for our organization that in this ED course, the example on the left, it talks about what was elevated, what the provider had a concern for, why they said they consider the patient to be so complicated to keep in this hospital, recommend to a higher level of care, and talked about why. I deem that in my organization as the reason for the transfer. They had that conversation with the patient. There are also other places in our document that I didn't snip because it involved a lot of the patient's history, and I just didn't want to share that piece of it, but it talks about presenting with such and such illness for such and such length of time, and it goes more into a narrative. But for this purpose, I mean, I feel like when I'm abstracting, this meets that criteria. But if I had concerns, there is plenty other places in the document too that go further into detail about the history of their illness and the reason for transfer. But I just wanted to show this one again, and this is why I say yes, we've met the reason for transfer.
Yeah, and that makes sense to me, Kelly. You were cutting out some pieces, but pretty much I would think on, especially to acute care transfers, we've talked about before looking at the EMTALA form, although you don't have to, but it is a source, and there's almost always, I think that it's partly kind of a necessity, that's saying why that person is being transferred. Any kind of discussion about like what Kelly had highlighted in there, in her note about needing a further level of care, or whatever. That's all acceptable. So that was fine. I'm sorry, I should have addressed that, but I guess because I didn't have any concerns, that one kind of just went by. Is everybody, and we're gonna, we do want Cindy to talk a little bit too, but this is great conversation. Anybody have any other questions about, and Kathy, if you have access to the ED transfer report in Epic, it will include everything that was documented in the ED. It's a static report that only includes the items in that visit. So that's in Kathy's Epic. Having that ED transfer report seems like it really has everything that we're kind of asking for, what was documented. Unless I don't mean to misunderstand you, Kathy. So if I'm reading that wrong, let me know or whatever. But
No, you're correct.
okay.
Kathy, this is Lynette Anderson. I just have a question in regards to that ED transfer report. So does your provider don't populate to that report prior to the physician being done with it?
Well, the physician is done with it before the patient is transferred in New Ulm. We are lucky. And that anything and everything that has been documented lives in that. So if they penned a note, it's not going to be in this report. But we've trained them that they have to be done with their documentation before the patient is leaving.
Okay. And again, that's kind of our hiccup. And our ED providers can't see incomplete notes at other facilities. They can only view the note at other facilities when it's actually done. So that might be like a different brand of like what Kelly has. And I know Epic has lots of versions. So that's part of our hiccup. And then the providers aren't wanting to send or print out an incomplete note because it might change. Or they might add to it, but I definitely like the time-stamped portion of what Kelly was showing. So thank you everyone for the input.
I have something quick to offer. One thing that we've ran into infrequently is we have a release of information process that pulls in all the bundles of everything necessary. And if we do that too early in the process, it actually can, exclude some of the elements because they weren't physically completed yet. So our team has the right effort of making sure all those points are there, but sometimes it's done too early and then not revisited prior to the patient leaving.
Hey, any other comments or questions before we move on to Cindy? All right, then. So Cindy, we'll turn it over to you to show us what you got for the documentation process. Do you want us to pull up your document or do you?
Yeah, I was just looking. We've used that transfer summary since 2004 and then updated it with the changes in 2020. Anyway, I'm Cindy and I've done this abstracting for this measure for about 7 years now. We're a 25-bed critical access hospital. Our emergency room sees 300 to 400 patients a month. We're staffed with one doctor 24 hours a day and one nurse and then some helpers. So when I first took this over, it was a little bit messy and with education, one-on-one education, we've done really well. And I think this form, if you scroll all the way down, this top part is what we call our EMTALA, where the doctor, does all the top stuff. And then on the bottom, that's more what the nurse does. She'll check off if, all the elements and the transfer stuff. She'll check on the left side if it was sent with, or if it hasn't been sent with, if it's not ready, she'll check on the other side if it was sent within an hour, or if we have a shared EMR. for our nursing homes, our nursing home we use Meditech as our EMR. So when we transfer to Essentia or Sanford up in Fargo, I don't think they have access to our EMR. So we're all trained in printing everything. One of the doctors will print his own provider note when he's done. The other doctors will tell the nurses when they're done, and then they print it with the rest of, the pay sheet and the med list and then the tests and the procedures. You've probably all heard of the PACS system. If that isn't done, it gets sent via PACS to X-ray. The radiology does that. So they, the nurse will check off that it's done. So when I abstract, I'll just take, and if this form isn't there, then I'll look in Meditech if they've got something. Sometimes they do miss this form, but I know 100% of the time they're always sending information when they refer, especially for to Essentia or Sanford. I mean, we've kept it kind of simple here, but all the nurses and the doctors know how important transferring all the information for handoff is. And they make a copy of this and they get the manila envelope and they load it all up and transfer it with the patient.
And I'm sorry, that makes me laugh, but that is like, it doesn't have to, and you say it's simple, but it's effective.
Yeah.
It's like, it can still be this, even in the age of EHR and everything being, everything being automated or whatever. This might be still the best way to know what goes with the patient. I mean, this is a great form. Thank you so much for sharing.
Yes.
Because I mean, it is right down the line. It went with the patient, check, check, check. Okay, it didn't, but we did, we sent it or we called or whatever. For this measure, okay, for showing that documentation that these things were sent, it does not have to be more than this, okay? If you've got this form in here and say all of these were checked, went with patient, and this is signed, that's the best that we can look for. We're not able to go that other step and say, well, we know for sure that it was. This form was checked, and we take that to mean it was. Okay, same thing with over here. Okay, they checked that they called, or they faxed it. This form was signed and dated. We take it to mean that's what it means, as long as, I would still look in the record and make sure that this stuff was there. I mean, if this was checked that home medications went, but I'm looking in that ER and there's no home medications, there's nothing listed about home medications, well, then I couldn't say yes. So, I mean, always remember in the back of your mind, you guys, you've got to make sure that this stuff is in the record, I'm not going to say yes, that the mental status went if I'm reading everything in that ED visit and there was nothing about, mental status or whatever. But if it's in the record and this is checked off, hey, that means we take it to mean that that's what happened. So I mean, this is a great form. And I think, Cindy, did you actually say you had a physician who copied his own note?
Yep. So Dr. Kalika, he'll print it off. He'll actually grab this form and start it, and then he'll print off his own note. The other doctors, you have to print it for them. Well, they'll tell you when it's ready, but actually the PDoc in our doctor ER provider note, it pretty much has every one of these elements in there, and they can pull all the tests into there and yep. So sometimes the PDoc, I pulled up one here and it's like 15 pages. So it pulls all that information into the provider note. So.
Thank you so much for sharing this. Again, we do know not everybody is able to have a form like this, or it's hard sometimes to make changes depending upon your hospital. You know, if you are part of a system, you guys at the smaller hospitals don't always get to say or can change things on your own. You have to go through the system. Things have to go through the corporate. And that's not easy, and it takes a lot of time, and sometimes you can't make any kind of changes, you know, so it's all, you know, that's why we really like you guys. Everybody is a little bit different setup. So sharing like this gives people ideas, or maybe what to look for or who to talk to. If if you've got Epic and you want to see, well, our Epic doesn't have this, maybe we don't, have this option, or how do we get this option? Or it gives you ideas of things to maybe ask about or things to do, which Senka and I can't give you because we don't really know them, so this all comes from you guys sharing. And it's great to have all of the different, when Lynette talked with Essentia and, how they function, and then some of the smaller ones with kind of the standalones, how they can function. Everybody's got something that's really valuable to share, because we the Stratus Health folks, me and Senka, we don't really know this stuff. We only know because you're telling us. That's why we've learned so much from some of this, and why I keep saying again, I can talk to you a million times about what the instructions say and what we're looking for, but then it's you guys at the hospitals that have to go and look at your record and find out what is available, what isn't, where you might have to work on things. Lynette, I don't need to be picking on you or whatever, but really appreciate you talking. Like you saying that, that your area has been around that provider note, and it is, and timing and the signature, it's all kind of tied together. So figuring out how that's working there, some of you other guys, even in our past meetings, talking about, we're really good at the acute care transfers, but it's our transfers to the nursing home where nobody wants to fill out this form, or we're trying to really struggle with getting them to understand that they have to document that, even though they're going back to where they quote unquote live. So I think the sharing on these calls have just been really invaluable. I've learned a lot myself. So can't thank you guys enough for doing this. So.
And I would also add I second everything that Robin is saying. And I would also add that you guys have all the ingredients. It's like really now just a matter of mixing and matching. And again, this is the point of these calls, for everybody to share and everybody learn, see, this is something that I maybe be able to take and implement in my own system. But this is just really kind of examples of what everybody has done. And if, there's some, good tools, tips in there that you can also replicate in your places. But again, you guys have all the ingredients. It's just about how do we mix and match them together to get to where we need.
And I think the underlying thing to remember is, yes, we're talking about the measure. It's a measure, okay? And, you're getting your scatter plots from us. So you're seeing where you are compared to the other hospitals in the state. I mean, we don't identify anybody, and on your scatter plot, you're the red dot. So you know where you are compared to everybody else. So yes, it is a measure. It's part of the MBQIP program. It goes to the Federal Office of Rural Health Policy. But the bottom line is, patients are seen in your ED. They're being transferred to another facility where someone's taking care of them. What happens in that ED needs to be told, shared, sent to that facility where that patient is going. And that's the bottom line. When you get pushback, and again, it's easy for me to sit here and say this, but pushback on this measure, pushback on whatever, that's the bottom line. Okay, if you were in the ED and all of a sudden you got transferred somewhere else, wouldn't you want that place where you were going to know what happened to you in that ED? Were you given a different diagnosis, a new diagnosis? What meds did they give you? That's what this is. That's the bottom line, not like, oh my God, I've got to document this, or, or we don't, I mean, these people are just going to the nursing home. We don't have to document this. No, you can't, you try to get everybody in the facility to not think like that. It's about patient care. That's my little extra about that. But I think sometimes we forget that because we're talking about the measure, and I'm contacting you saying, did you get your measure data in yet? And we're, so yeah, it's a measure. Yes, you need to report on it quarterly, but the bottom line, it's about good patient care.
So guys, this again, really, really amazing work. Kelly and Cindy, thank you so much for your thorough review of what you're doing, and just really some amazing tools and tips on this. I want to open it up now. Are there others on the call that would like to share a little bit about their work around documentation, kind of what they've seen work better, and what you've done, kind of what you've seen and been able to improve? If anybody wants to take a moment and share a little bit, or if there are any other questions or comments.
Oh, and somebody put a comment, but just again, then I'll be quiet. You can't really improve what you can't measure. It's kind of like measure is the first part of figuring out what needs to be improved, and that's part of the reason why, yes, it is an all or none measure. When you look at the measure, either you meet all those data elements so that case passes the measure or not. But from a quality improvement standpoint, it is important to look at the individual measures, because there might just be one measure or two measures or two data elements that you're kind of falling down on. It might be you're really great on current meds and mental status, but your allergy reviews are terrible or whatever. So that's, that would show you where maybe that you need to have some focus on the documentation or whatever. So from a QI point of view, the individual data elements kind of come into play more than the overall measure.
Hi, this is Tasha from Wellia. I just want to go off of what you just said. That was us. We were missing a certain measure in particular of the whether or not we were following up on our cultures or our lab results, which we know we have, but we didn't have documentation to prove that. So we did, off of some of the previous meetings we were in, we did add a statement to our transfer report. So now we're hitting that mark 100%. So that's helped us extremely well on hitting that measure. We're still not hitting all of them 100%, but we did in March.
Well, that is great.
Yes.
And again, it can be, and I don't mean it to say as simple as that, because I know nothing is simple, but for that one data element, yes, because we ask what it all is about is if that result isn't ready at the time that the patient leaves, or within the 60 minutes of the patient, leaving, is there documentation on how that's going to get to the other facility? So it just is there documentation saying how it's going to get there? We're going to call when it's ready. We're going to fax it when it's ready. We don't ask, because we can't. We can only take it so far. We don't ask you to check and make sure that happens. In the perfect world, and in a QI perfect world, that would be the step to take. Not just that you said you do it, but did you really do it? But we can't go that far with this measure. It's just like documentation indicating how you will get that data there when it is ready. So, yep, a statement like that on your form is fine. Thanks for sharing.
So guys, I want to tell you, Robin here is behind the camera. She doesn't have her video because she's always doing her happy dance when she's on these calls and hears all about the great work that you're all doing. So Robin here, I can tell you, is very, very happy.
Well, I have to say, and again, I probably say this all the time too, so forgive me, but it means a lot. I mean, Senka and my role here is to make sure that you guys are reporting, and then to help you increase, your measure. And when we talk with you guys like this, especially on EDTC, it means a lot. I have like faith in you guys doing it well and doing it right, and I don't know, and sometimes I think nationwide our scores might look a little bit lower because I can't speak to everybody else's concern for making sure that the hospitals in their state are doing more than just submitting the measure. I mean, it isn't just about, it is about submitting, but it's also about submitting it correctly, and I would rather that maybe we're not always like, in the 90%, but we're accurate with what we're submitting. I think that's more important. And if everybody would just listen to me, then we would be really great. But you guys, and I let this be known, so it's not, I mean, everybody at the federal office has heard way a million times how I would, I stake my reputation on what you guys are submitting. And I don't think a lot of other states could say that or whatever. So, and no, there's never going to be a happy dance shown anywhere. So Senka just needs to be quiet about that. So
We'll have to figure out, Tracy, how to get her to turn on that camera. So guys, this is fantastic. Again, kudos, props to you. The fact that you all are putting EDTC as one of your top priorities, given how so many others you have. Again, you guys are doing amazing work, and thank you so much. Our next call is going to be on August 16th. We are going to continue these conversations. Again, it does help to have guest speakers in the beginning of these meetings. So we will be reaching out to a couple of you, to maybe do a little presentation next time to kind of kick us off with these conversations. But again, super helpful. Again, you guys, you have the best practices. You have the right ingredients. It's just really now mixing and matching, to get the scores to move, and they have moved. I mean, we are seeing now when we look at those scatter plots, the scores have moved. You have all moved your scores in a positive direction. So good work, guys. Keep it up. We'll talk again in a couple of months. Thank you all.
And
Robin, go ahead.
Just one last thing. If anybody wants to, we've been doing kind of one-on-one calls, and I don't know that we've gotten to everybody yet. But if you've got, a question, or you've got a form that you would like to show us and say, hey, can we take this from here or whatever? We don't know what your forms look like, but if you ever wanted to send, or take a screenshot of something and say, hey, could we use this, or can we pick this from there? You guys can always, send me stuff, and we can talk about it, and if by some chance we've missed you for a one-on-one call and you want to have a call with us to talk about EDTC, just like let us know, that's what we're here for or whatever. So.
Yep. Absolutely. Thank you, everyone. Have a great rest of your day and weekend, and have a great Memorial Day weekend too.